Good morning, everyone. It's my pleasure to welcome you to our State of the Science webinar on lessons learned from central disorders of hypersomnolence and future directions. My name is Phil Gehrman, and I'm the current president of the Sleep Research Society Foundation. And I'm really excited about this event today because it really captures what the Sleep Research Society is all about. It's about bringing the latest science of sleep and circadian rhythms to advance knowledge and public health as well. And so I'm really excited to hear the conversation for today. I want to thank our corporate sponsors for today's event: Alkermes, Avadel, Axum, Centessa Pharmaceuticals, Eisai, Jazz Pharmaceuticals, Takeda Pharmaceuticals, and Zevra Therapeutics. It's my pleasure to pass the baton over to Dr. Anne-Marie Morse, who's a pediatric neurologist and sleep medicine specialist at Geisinger Health System, and also a current board member of the Sleep Research Society Foundation. So Anne-Marie, I will pass it over to you.
Wonderful. Thank you so much, Phil. I have to share my enthusiasm the same as you. I think that this is really speaking to what the mission of Sleep Research Society is taking all the amazing research that many of our members are producing and being able to tie it together with some of my really great sleep friends who are joining me here today to be able to talk about what is the current state and what are the things that we should be excited about. And so today we are going to talk about the lessons learned from central disorders of hypersomnolence and what the future directions are, but we're not going to stop there. We definitely are going to be incorporating all of the types of sleep disorders that are relevant to this conversation because we recognize that that is necessary for us to be able to make the meaningful changes that are necessary. Now, I'm going to first ask Dr. Atul Malhotra for him to provide an introduction, and then we'll hand it over to Emmanuel and then Phyllis.
Great. Thanks very much, Anne-Marie, and thanks everybody for inviting me. My name is Atul Malhotra. I'm a pulmonary critical care sleep medicine physician at UC San Diego. I'm the vice chair of medicine for research and as president of the American Thoracic Society some years ago. My primary expertise is in respiratory science, which makes me wonder why I'm here, but I will be happy to learn from all of you and chime in where I have something to add. So Emmanuel, please go ahead.
Hi, I'm Emmanuel Mignot. I'm director of the Center for Narcolepsy at Stanford University, and I've been working on narcolepsy for many years, as well as on orexin hypocretin.
Wonderful. And Phyllis.
Hello, I'm Phyllis Z. I'm a neurologist and practice sleep medicine. I'm at Northwestern University Feinberg School of Medicine in Chicago, which is very cold right now. And my area, I guess, of expertise is in circadian rhythms and circadian biology.
Wonderful. And so as you can see, even though this is a topic about lessons learned from central disorders of hypersomnolence, we were purposeful in including experts from a variety of different areas because it's necessary. Just because a person has one sleep disorder does not mean that they can't have other sleep disorders. And when we're learning about sleep and circadian science, it's relevant for us to have all the key stakeholders present in order to have the most fulfilling conversation. One comment I do want to make before we move forward is that I do acknowledge, we all acknowledge that Dr. Mignot's volume is a little bit lower than what he would prefer it to be, but we are very grateful because he's actually tuning in to join us from Paris. And so with the volume limitations, if there's things that may be more difficult for some of our guests to be able to hear, we will be trying to—
Can you hear now?
Yes. You see in live, this is him using all of that knowledge. Wonderful.
I know, I had to use my French connection. No?
Wonderful. All right, so now there will be no limitations. He was just keeping us all in anticipation. All right, so today's learning objectives. We are going to learn to identify the pentad and non-pentad features of narcolepsy. Now, I know you probably are all exhausted from hearing lecture after lecture, didactic after didactic about the pentad symptoms. However, part of the reason for us to positively reinforce this concept is because we know that the people still struggle with recognizing those. However, one of the things that we're going to lean in today is really talking about those non-pentad symptoms. And again, this is the reason why we have all these experts on the line to be able to discuss this, because of the fact that we need to be able to recognize where these patients are actually presenting. They may not necessarily be in a sleep first. The next piece is really being able to understand the role of orexin in sleep-wake control, and who else other than Emmanuel Mignot to help us really dig into that. Finally, understanding and characterizing the role of orexin in non-sleep processes. This becomes really important for us to be able to understand that sleep and circadian influence to non-sleep processes in general, and then how orexin may be playing into that. So the agenda for today, it is definitely a stacked agenda. So you have 90 minutes with us, and I'm already eating into the first 5. So we're going to lay the foundation of sleep and circadian science, really starting to create those connections for sleep-wake health, and also understanding what happens when there's dysfunction. We're going to talk about sleepiness, hypersomnia, hypersomnolence. Is that the same? Maybe. No, it's a little bit different. Then we'll talk about the central disorders of hypersomnolence, the who's, the what's, the why's, and the I don't knows yet. The transdisciplinary considerations that are going to be necessary for us to understand the burden of this disorder. And then also, what does that future direction looks like? How are we moving forward? And how is discovery and development changing tomorrow? So let's start out with laying the foundation of sleep and circadian science. Well, first and foremost, when we're looking at the developmental sleep needs, I'm a pediatric neurologist, guys. So yes, although I do adult and pediatrics for central disorders of hypersomnolence, I run a division of child neurology. So I'm all about developmental milestones. And when I look at developmental sleep needs, both in terms of duration, but also on the next slide, we'll talk about the circadian distribution. This for me is an unadulterated representation of brain health, and really is giving me that when my brand new baby, newborn to 2 months old, requiring 14 to 17 hours of sleep, that is not by accident, it is by design. And we see how this duration changes over time. And with that, we are also seeing that you see these developmental changes of having this fragmentation that is very purposeful in the first year of life, and then that starting to become more consolidated to this nocturnal preference. For me, I very frequently will look at these type of developmental changes or this normal ontogeny of sleep and utilize this not only as my initial framework of making sure that I'm asking the question, see if a person I'm speaking with is falling into this normal developmental pattern. But on my flip side, when I'm not seeing someone for a primary sleep-wake disorder, but seeing him for a primary neurology disorder, this also is just as contributory. So before we move on to the next slides, I just want to get a sense from the rest of you. When you're maybe teaching on this or seeing patients in clinic, you tend to see more on the adult side. I know, Emmanuel, you see some pediatrics as well. How does this play into some of your framework of thinking about not only sleep-wake disorders, but perhaps other medical, developmental, psychiatric type of conditions that you might see as well in patients you're taking care of?
I think it has, of course, implication for narcolepsy type 1, since, one of the things you always try to do is to optimize the amount of sleep that you think is, developmentally needed. So sometimes you have problems, for example, with using sodium oxybate because you just can't get, 10 to 13 hours with the half-life that you have with 2 administrations. So occasionally I give 3 administration, or I ask the patients to sleep first and then to take more, but that can also become very difficult for the parents. So certainly yes. I take this into consideration for NT1 in the use of sodium oxybate and the use of stimulants, because you will maintain their wakefulness in a appropriate wake time amount. And then of course for type 2 idiopathic hypersomnia, often it's quite rare in children, but certainly if they sleep a lot, it has to be more than their normal sleep amount for it to be significant.
Yeah. And I also think that it becomes relevant to the point you're describing. We're talking about narcolepsy, but for Phyllis, someone who's expert in circadian rhythms, I would say that also becomes an important differentiating point of, are they getting, we were talking about this earlier, are we getting the right timing and duration, and how that interaction, especially in our adolescents, where sometimes a hypersomnolence disorder can be misdiagnosed as a hypersomnolence disorder, where it may actually be a delayed sleep phase or otherwise. Any additional comments from you, Phyllis?
Yeah, no, absolutely. The other issue I wanted just to bring up is the consolidation, right? You have these as sleep duration, as continuous blocks of sleep. And especially as we think about older adults, one of the questions I always have is sleep fragmentation, or at least multiphasic sleep, normal as you get older, just like it is in newborns or children? And how much is too much of the fragmentation as you get older? So it's I think that's a question that is evolving in the literature, that maybe we weren't really meant always to sleep in this super consolidated manner. And in narcolepsy, you know, like if our treatments of sodium oxybate, you know, it is twice a night, but perhaps that's good, perhaps that's bad. So something conceptually to think about as we go into some of the disorders.
Yeah, Atul, what are your thoughts?
Yeah, I just have a question for you and Emmanuel, I guess, and that is regarding the oxybates. I'm wondering how young you go with those medications, just because I think of the mechanism largely related to improving slow wave sleep, and many of them already have a lot of slow wave. So I wonder if you see diminishing return with reducing age.
Yeah, I'll let Emmanuel go first, since he clearly is extraordinarily expert and has many more years experience than I do. But I would be interested to hear his response, because I do know he uses it across a wide range of ages.
That's nice to say, but before answering that question, I mean, Phyllis made me think of one thing that was important. Of course, for idiopathic hypersomnia, which is often a bit complicated, is we often have young adults. And these young adults have terrible trouble waking up in the morning. And of course, when you see that, they have sleep inertia, you think, oh my God, delayed sleep phase syndrome. And of course, in these cases, it's a little bit more complicated, because often they sleep a lot during the day and they still have long sleep time and they still wake up tired, etc. So it's not like they wake up tired even when they just go to vacation. They will still wake up, have difficulty waking up even later. But sometimes, you know, the overlap is a little there. And I still have a nagging issue about circadian rhythm being abnormal in some idiopathic hypersomnia patients. So I just wanted to get that off of my chest. Even so, there's a paper by the great Dauvilliers that claims that there is no difference in circadian rhythm in idiopathic hypersomnia. His definition of idiopathic hypersomnia is somewhat reductive. So I think this is still a question in clinical practice with how much circadian rhythm could be involved in some idiopathic hypersomnia, or even narcolepsy without cataplexy, since REM sleep is also very circadian. But
so Emmanuel, we're going to get into this just a little bit later. We're having that discussion. Timing, which is what Eve's looked at, timing of one rhythm, right? Of the core body temperature rhythm. Timing is, we need to be thinking about circadian disorders much more broadly, or circadian disruption more broadly than timing. The amplitude is clearly a problem there, right? Because your day-night differences between sleep and wake and rest activity. So we need to think about more broadly, but we'll talk about that in a little bit.
No, you're right. Sorry, Phyllis. I realized I should probably.
We are going to dig right into that. What I do want to know, Emmanuel, is to answer Atul's question in regards to oxybates. What's the youngest that you've used it in, and what has been your experience?
Yes.
Do you see diminishing returns on investment when you're utilizing oxybates in younger ages? And it's important just to frame out for our audience that oxybates are technically FDA approved for 7 years and older. And so conversations around outside of that are off-label, but it is something that we utilize in clinical practice. So would love to hear what your comments are, Emmanuel.
Yes, oxybate is a very strange drug. When we use it in narcolepsy with cataplexy, when it was first indicated and discovered in the 1970s, believing it or not, you realize that you have a relatively immediate effect on sleepiness and cataplexy, but it's really partial. And what's really curious is that it's only when you use it regularly that you get the full effect. It takes like weeks, if not sometimes months of use to have the feeling that the patient really gets rested. Mm-hmm. I always have felt that if there's such a thing as a chronic sleep debt, that Xyrem may have an effect not only on acute, but also on chronic sleep debt, that it makes people super rested little by little, but it takes a while to get its full effect.
Yeah.
Now, it is correct that it's still a mystery why it mostly promotes non-REM sleep, and Atul is absolutely right, and why would it have a positive effect on things such as cataplexy, which are believed to be REM sleep related symptoms. And to be absolutely honest, I'm really happy to say that I have no clue. This would need to be studied. I just want to point out that maybe there are a known relationship between non-REM sleep debt and REM sleep debt that we don't fully understand. For example, rats that you chronically sleep deprive even acutely for very, very long period of time. The first thing they do is they go into REM sleep. So it's a bit, there might be relationship between REM and non-REM sleep that we don't fully understand. That would be just a general comment.
Yeah, Anne-Marie, do you see less efficacy if there's more baseline slow wave sleep? Is that because
no, you don't. And in fact, one of the things I would say is interesting is that we now know that we have 3 different oxybates that are available. We have twice nightly sodium oxybate, twice nightly mixed salts or low sodium oxybate, and then the once nightly extended release oxybate. And so what's fascinating is that although in individuals who have idiopathic hypersomnia, has been debated back and forth of it, do they have augmented slow wave sleep? At baseline, and that has been relatively refuted, that there's not necessarily an increased slow wave sleep. However, again, I think it's population specific, and to the points that Phyllis and Emmanuel had made already, it's a very heterogeneous population. But if you were to take them as just a baseline, that patient population in the mixed salt study were very, very robustly affected in a positive way. We're able to have a very different dosing profile utilizing a once at night of a twice nightly oxybate and lower dosing, so less than 7 grams in the double-blind randomized withdrawal. And that was replicated with similar type of benefit in individuals in Eve's group, where he did a randomized control trial with sodium oxybate twice nightly, and again, demonstrating by week 4 normalization of things like the IHSS and the Epworth Sleepiness Scale, as well as improvements in maintenance of wakefulness test. I am going to go on to the next slide so that we can continue this conversation, but start introducing other concepts that we want to make sure we're laying the foundation with. But do recognize that Phyllis also has her hand up.
Yeah, Anne-Marie, there's a question in the chat about how the oxybates are administered. I think you kind of addressed that, but two divided doses or the single long acting, right?
Yeah, so if it is yep.
And I think that one thing you said is not really completely, I mean, I think the controversy is whether or not Xarem or sodium oxybate creates normal slow wave sleeps.
That's a good question as well.
I don't think there is. But I don't think there is any doubt that it produces, intense slow wave-like activity.
Yeah, that was my point. Yeah, Emmanuel, absolutely. So I was thinking, the way we measure slow wave sleep or slow wave activity, is that the right measure of the brain state stability, which is probably what's happening to some extent. Yes. And I don't think we have that. So for example, if you look at IH, they have a lot of slow wave sleep, the way we measure it, right? And yet it helps. So I don't think we're actually measuring. That's not necessarily a good proxy right now anymore, perhaps, for what's happening.
And I think on the next slide, we can come back to that concept. So I think on this slide, I'm going to go through this really fast so that we can get into the next 2 slides, because I think that there's more meat there, and because we still have so much more content to cover. So when we're looking overall, just to give a framework, this is really what I think many of the current state teachings are, is that we have some genetics that are going to be basically the instructions of the body, giving some direction as to what our genetically prescribed homeostatic drive may be for our individuals, and then our genetically prescribed circadian rhythms. And if it was just up to those pieces, this would potentially control sleep-wake cycle, again, giving a very rudimentary idea of this 2-phase concept, and that what we're learning and what we've seen in research is that there are these other external factors that can greatly influence what our expression of sleep-wake cycle look like. And in this illustration, we're just talking about stress and illness. And if there's an innate sleep-wake disorder, temperature, both internal body temperature as well as the external ambient temperature. We commonly will make that recommendation in regards to sleep hygiene, making sure you're falling asleep in a nice, cool environment. Talking about food, and I know, Phyllis, you've done some really great work looking at not only the type of food, but the timing of food, and how that may also influence circadian rhythm. And we can't forget about medications or other substances. But I think that this is probably a slide that many people are familiar with, is looking at homeostatic and circadian drive for arousal. And I think when you talk to the public, there many times is this misconception that the circadian rhythm is what's putting you to sleep, and that melatonin is putting you to sleep. And I think that this slide by itself is giving you a nice rudimentary idea of the interactions of these processes. The next slide that we're going to dig into is going to further enhance the complexities. But I would love for Phyllis, for you to kick us off with, when you're seeing this, because you had shared with me earlier a question that you had asked for there to be a description on how would you illustrate these interactions, or how would you teach these interactions? Can you restate that? Because I think that was a really powerful or impactful description.
Exactly, do that. I want to kind of look at the sleep gate. It's also kind of this little forbidden zone for sleep that Perez-Levy talked about many, many years ago. And it is truly that interaction between the buildup of the homeostat, where you're really needing to dissipate that, and yet the circadian alertness signal is still high, right? And then when both of them go, when the circadian signal goes down, homeostat is high, you get this consolidated sleep. So when we were talking about a little bit earlier, I asked the late Steve Brown when he gave this great lecture on the interaction between homeostatic and circadian influences. And I said, can you just explain to me simplistically, because I don't, get all these proteins and everything. And he was talking about protein regulation. And he said, well, I think you could think of it as the circadian system tells you when, and the homeostat tells you how much of that protein gets made. And therefore, you have to have both aligned in a way so that because the timing also dictates how much, but the homeostat also dictates how much. And so it's really that interaction. So I thought that was really an easy way for me to comprehend at all levels of organization, not just at the physiology or systems level, but also at the cellular and molecular level.
Yeah, and when you were sharing that with me earlier, I had said that on LinkedIn, I had recently shared a post because there was a paper that was published that one of my connections had shared. And I was just like, oh my goodness, I can't believe how ignorant I've been for so long, because it was about the amplitude of the circadian rhythm, not just the timing. And it's such an interesting concept because we generally are qualifying circadian rhythm disorders by their timing. But when you're thinking about the fact that it is an interaction, if I have a difference in amplitude, the timing might be exactly as it should be. But if the amplitude is higher or lower, that sleep gate is either going to stay closed or be open for too long. And I think that that's a really interesting concept.
Yeah, absolutely.
Emmanuel, how do you feel, or how do you describe to maybe it's your sleep fellows or when you're giving lectures, how orexin is playing a role in our understanding of this homeostatic and circadian relationship? Because we see that there is this diurnal expression of orexin, and that it very much is responsive to the homeostatic drive. It seems like as we're accumulating sleep debt in a person who doesn't have orexin dysfunction or deficiency, that wants to increase. What is it that you think that is important for people who are less familiar with the orexin in regards to sleep-wake control is important for them to hear or understand?
What I generally say is that there is a misconception in the way the circadian clock works, that the circadian clock doesn't make you awake all day and sleepy all night, that really it makes you awake in the evening and makes you sleeping more and having more dream and REM sleep in the morning. And as a consequence, a simple way of dividing the day in 4 quadrants. The first period after you wake up, you're awake because you have no sleep debt, but your circadian clock is not very active. The second you start to have a sleep debt, you're tired, but then your circadian clock keeps you awake. The fourth quadrant, you fall asleep because you have a high sleep debt and your circadian drive drops. And the fourth quadrant, the circadian clock makes you sleep extra, but you have no more sleep debt and you have REM sleep. So that's generally how I kind of try to explain this kind of two-process model. But it's clearly an oversimplification, and
Sure.
we see it in many, many aspects. I think it has what we call heuristic value to explain, to a lay person how it works, but I don't think that's how it works molecularly. Most likely, that's not the way things have been probably selected. So, for example, orexin, like body temperature, is dependent on both circadian drive and sleep debt. And probably most factors are the same because it seems more logical. And for example, orexin, goes up when you try to stay awake, when you sleep deprive yourself, which is counterintuitive because it makes you awake. So it's just trying to keep you awake when you are a little sleep deprived. And it's also higher in the evening when you're naturally more awake because of the circadian clock, which Phyllis explained very well, is really this forbidden zone, circadian drive for alertness when you're really awake independently of any sleep debt, the second part of the day. And so a lot of factors are probably involved in both circadian and some aspect of homeostatic drive.
So I have a question in the question box, but I have a question for Atul first before I address this. Atul, many people who may be in the Sleep Research Society know you as an amazing sleep scientist. But one of the things that I'm incredibly impressed with is that not only are you an incredible sleep scientist, but you also are an intensivist who is studying there. And many times those worlds can collide. We see that delirium and worse outcomes, I think this has been best represented actually in the sepsis data, but has been replicated across other disease processes, of that when there's circadian dysfunction in an intensive care unit patient, that is going to enhance their likelihood of delirium. It's going to increase morbidity, mortality in those individuals who have sepsis, but this again has been seen in other diseases. One of the things that I think is very interesting is that we do see, and we're going to talk about this interaction even more in the next slide, but we do see that the homeostatic drive can influence our circadian expression. And some of the things that we see here in this little bubble influencing the augmentation of the circadian drive are inflammatory factors, nitric oxide, tumor necrosis factor alpha, your interleukins. And interleukin 6 is an interesting one because there's also data that has been published to give a suggestion that might increase your blood-brain barrier permeability some. It may exaggerate some other negative consequence. What are your thoughts when you look at this and how that reflects intensive care unit practice and what else we may want to think about in regards to that?
Yeah, that's a tough one to capture in a soundbite just because there's so much going on. It's not an easy thing to study. People have tried, smart people have tried, and there's not great data in that context, but there are ongoing efforts in that space. The main zeitgebers are sort of messed up there. So a lot of those patients are arrhythmic, like the light stimulus is quite erratic. The food entrainment oscillators that have been talked about are also very unclear with continuous feeds. And so it is a bit of a mess, but I'll say most of my patients are arrhythmic. One study, the median sleep duration uninterrupted was 6 minutes, I think. So they're very, very fragmented sleep. And I agree, delirium is one of many issues that arises there. That's been associated with worsened outcomes, prolonged length of ICU stay, prolonged duration, mechanical ventilation, and long-term neurocognitive sequelae. So it is a big problem, not well studied.
Yeah, and sometimes it's a question of, for myself as a neurologist, sometimes the chicken or the egg. Is what we're seeing, because we see this in the NICU all the time, are what we see when we're doing an EEG in terms of the level of dysfunction, is that just because of the innate brain dysfunction? Or is it a causative or outcome of the environment and everything else? Renee Schauhaus had done a beautiful work of looking at EEG and utilizing the sleep-wake cycling of a neonate in the ICU to predict neurocognitive outcomes at 18 months of age, demonstrating increased time spent in quiet sleep was actually associated with lower cognitive performance. So again, really unveiling this really important component. And I think as I go into the next slide, I'm going to ask you two of these really great questions that I put in the chat. So question number one is, what is the biological process that upregulates circadian amplitude, not timing? And then for Atul, is anesthesia sleep? So Phyllis, I don't know if you have any thoughts on the circadian amplitude piece and what might upregulate or downregulate. Emmanuel, please, if you do as well. Obviously, if I ask one person and others have input, I would love to hear it.
Yeah, it's really that the amplitude is the difference between day or night and or rest and active cycles. I think probably at the if you look at the cellular neuronal level, you can actually see that amplitude in the activity of the suprachiasmatic nucleus neurons, right? You can see that the strength of the firing. So it's probably the collective firing together of these neurons and or of the molecular mechanisms, right, that are more so during the night versus during the day. And probably also when we measure peripherally, like we measure, most things, it's probably the alignment between the central and peripheral clocks and kind of the unity, how they are firing, how they're active in phase relatively with each other. That's what I think.
Do you think that there's a clock gene contribution to that as well, the amplitude?
Oh, yes, absolutely. These clock genes are the ones for cycling, right? So how they're cycling, for example, in the liver and in the muscle and so forth, and how the SCN is regulating also all that timing. So it's really the orchestra, right? So if the peripheral clocks, the central clocks are strong, they're robust, right? And they're in phase, then you get the big amplitude.
Atul, is anesthesia?
Yes, I think.
Oh, sorry, Emmanuel. Go ahead. I apologize. Emmanuel.
No, I think I wanted to, re-mention what exactly Phyllis said, but with one little thing. One of the problems with amplitude is we don't have a good definition. What is amplitude? Is it amplitude of movement? Is it amplitude of alertness? Is it amplitude of hormones? And I think that's one problem.
Sure.
We don't have a very strong word. Phase, the same way we have phase of certain proteins, there's phase of melatonin, but at least kind of everyone agrees that the phase of melatonin represents roughly the phase of the entire organism, or at least the primary central phase. But for amplitude, we don't have any clue. So the definition makes it difficult to discuss. But I think in general, I would agree with Phyllis that it's probably reflecting something to do with the synchrony of all the clocks, peripheral and central clocks that have to pick at the right time and really maximize their effect together is one aspect. And another aspect may just be the strength of each individual oscillation, but we don't know that.
Yeah, and we're going to come back to asynchrony in a moment. First, Atul, is anesthesia sleep?
Well, first of all, Phyllis has done some great work as well in critically. I'll call on her as well because I'm interested in her comments. But I'll say a couple of things. One is, I don't know. There was some data. I read about this when Michael Jackson, when that fiasco happened with his death. And I read a fair amount about propofol in that context. And there were data from sleep-deprived mice where you could give them propofol anesthetic and see some dissipation of homeostatic drive. So there's some restorative effect of anesthetics. Clearly, it's not ideal. Certainly benzodiazepines are a risk factor for delirium, and so that's not ideal either, even though you can see some spindles and what looks like stage 2 sleep in some contexts. The other point to make is the guy Mervyn Mays up at UC San Francisco, who did a lot of work on Precedex, which is also dexmedetomidine, which is an alpha-2 agonist. And the interesting thing about it is if you lesion the ventriculopreoptic area, in the sleep center in the brain, that drug doesn't really work. And so there was a lot of speculation. It was inducing sleep, not just sedation. It wasn't just sort of GABAergic suppression of the brain non-specifically, but particularly through the sleep center. And when you saw patients on that, you could wake them up. It looked like sleep more than just sedation. But when you look at the randomized trials of propofol versus dexmedetomidine, large-scale randomized trials have not really shown benefit. So the theory didn't really bear out in practice, although, I'd love to be proven wrong if there are further studies that are in the pipeline. The other point I'd like to make briefly is that the question you asked about chicken and egg earlier, I think is important. So my friend Wes Eli at Vanderbilt in Nashville has done some work on the ApoE4 gene as a risk factor for delirium and seen some link there. And even though that's a genetic risk factor for Alzheimer's, it does suggest as you're suggesting, Anne-Marie, that some genetic predisposition may contribute to both delirium as well as dementia, and that would suggest it's a vulnerable brain more than a chicken and egg kind of situation.
Yeah, and I think that that's a very, very interesting concept. I think when we look at this anesthesia sleep question, it is one that is really important because, one, there was a shift in pediatric sedating practices for a while with the concern of repeat sedation for children has a neurodevelopmental consequence. And so we were being very, very cautious about that. There was just recently a study that has now refuted that idea. And so it is an interesting concept when you're thinking about, is there a potential risk associated with that? How does that affect developmental or cognitive outcomes, and really trying to understand this entire dynamic. Similarly, in epilepsy, we're constantly looking at the fact that you are more prone to epileptiform discharges and you're more prone to seizure coming out of sleep. And so what do we do when a person is in status? We are pharmacologically sedating them and putting them to sleep with anesthetics. And so it is a really important factor for us to be exploring scientifically because there's implications for it beyond just sleep, wake, and circadian control. It's across disease states. Now, the complexity only grows with this amazing publication that Emmanuel and Phyllis and Atul had suggested of including in today's presentation. And this is one of the things that I love about doing these types of events is I think that we all end up learning something every time. Now, with this is really a beautiful publication that came out earlier this year, and it really is giving a great description around the transcriptome and having this description around the fact that there is a differential contribution of a forced desynchrony when you look at different organ systems. So to the point made of measuring melatonin or measuring body temperature or measuring any singular area may be quite erroneous because we may find that there may not be a change in one area, but we may see it in a different area. And so when we looked at the prior slide, that really was giving some inputs around our sleep-wake control. This now is taking this a step forward. When you have sleep-wake dysfunction, how does that impact this normal expression of what we should see from what is genetically determined to be transcribed into your protein? And so, Emmanuel, I know you've done a ton of work in genome-wide association studies. There now is emerging literature around protein-wide association studies and the study of proteomics. How, for the three of you, when you see this type of data, what are some of the things that just come to mind, either in terms of your own research, clinical practice, or questions that us as a field need to be combining with in regards to other organizations and other scientific areas to lead to even more discovery?
I can take that one, or at least some of it, since I'm trying to do some of that. I really think that our interventions right now in the sleep-wake area, besides narcolepsy, where we know the cause of it, are really like we're in the fog. We don't have a clue of what's happening, why people are tired, at what time, even the symptoms, do they fall asleep, are they just foggy? And so I think we have to step back and maybe we look back at some of these basic circadian and sleep drive and how they could contribute to being hypersomniac or narcolepsy without cataplexy. And in that respect, I really think we need to measure circadian clock in some of these patients with hypersomnia better. I hope Phyllis, I'm sure, is going to discuss that. I think we need to look at peripheral synchrony, in these patients as well. I think we need to have biomarker sleep depth. We don't have those really, and that will be very helpful. And now with all this possibility of doing multi-omics, where we can really measure thousands and thousands of things, you have the possibility of getting an insight into these processes separately. Also, we need to agree, how we are going to define, for example, an amplitude. Is it going to be the mean amplitude of all proteins or all transcripts at their ideal phase, or is it, so there's a lot of questions, but I think the discourse has to move from a single two-process model to a multi-process model. both considering peripheral circadian rhythm and also many correlates of circadian rhythm together and of sleep debt together. And I suspect, you know, Phyllis is in agreement with me because we're generally in agreement, but maybe not. But I'm sure she has also some other things to add. But it's an exciting time with the omics going on.
Emmanuel, before Phyllis makes a comment, Emmanuel, one of the things that I would also add to that is that we know that individuals, and we'll talk about this again a little bit later on, but I want to start planting the seed now. We know that individuals with hypersomnolence disorders, and especially individuals with narcolepsy, are more inclined to having a variety of other medical and psychiatric comorbidity over time. And so one of the things that we recognize is although central disorders or hypersomnolence are not considered circadian rhythm disorders, they clearly have circadian dysfunction in terms of just their patterns of sleep across the day. And it starts to introduce this idea as to whether or not what we're seeing, again, going back to chicken or egg, and this is going to continually be kind of the theme, is this what's underlying some of the diverse challenges that we see? Is because every individual who has one of these conditions are different from one another. There's no this is exactly what this condition looks like. Even when we're describing pentad symptoms, there's variation, but the non-pentad, we see even variation. And so this really starts to give us some foundational concepts as to why we may see differential expression of these disorders. If you take them as a group, we see increased risk, but then when you look at it more globally, you're now starting to go, okay, this might give some explanation. It also may give some additional backing to the Windred et al. Paper from January this year, looking at regularity of sleep and showing it blows out of the water duration of sleep in regards to all-cause morbidity and mortality. Phyllis, go ahead. I know you're chomping at the bit. You're muted.
Yeah, I had actually.
I always agree with Emmanuel. So there you go. But I think what it speaks to me is that it is time now that whenever we think of studying or doing research in any of these sleep-wake disorders, is to think of this interaction. It is the interaction that likely determines health and disease. And, you know, historically, we try to separate them, right? The force of synchrony, or we're trying to separate these things. But instead, I think the challenge for the future is how do we integrate these two? And that is a big lift, right, Emmanuel and Atul, a really big lift. But I think we have to focus in how can we do this at every level of organization.
Yeah, Phyllis, I think you just gave us the quote of this state of the science is how do we integrate sleep and circadian science, the homeostatic drive into circadian expression, not only in sleep science research, but across organ systems. It really is the call to action. Emmanuel, what were you going to say?
I was going to say that in that respect, I've always liked this old saying that Jouvet was using. He was saying that really circadian rhythm were predictive homeostasis. You know, the role of circadian rhythm is to get the warm before everybody else. I mean, it's to be prepared to the change that's expected based on light dark cycle. And the classic homeostasis is more recovery homeostasis or reactive homeostasis, which is really when you overuse something, you have to go back to the level of, and in some ways, you know, if you apply this concept, then it becomes a little bit more logical to think that they are so linked, because every system is going to try to do both. Yes. I think in some ways this duality has been maybe a bit forced on us.
Yes.
In a way that's not good. And I think we just need to go to a retreat in a very nice place with Phyllis and just get a very nice new definition.
Yes, yes. So that is a message to Sleep Research Society to send us on a retreat so we can help in facilitating. No, I'm just kidding. So believe it or not, guys, we're having so much fun that we actually only have about 42 minutes left in this symposia. And so I do want to make sure that we get through some of this nuts and bolts here. We have another great question, and it actually is perfect with this. So sleepiness, hypersomnolence, hypersomnia, the same but different. Very frequently, I attend different educational activities, and I would say even more so when I'm speaking with some of my colleagues and peers. These words get used interchangeably in the same individual, and they're not the same thing necessarily. And this is not even introducing the other concepts of sleepiness versus tired versus fatigue. Those are very, very different. But when you are talking about sleepiness versus hypersomnolence versus hypersomnia, if you had a patient in front of you or you had your trainees in front of you, how do you educate on what each of these are and what the distinctions are? And I throw that to any of you.
Can I make a point while they're thinking about it? You mentioned it tangentially there, Anne-Marie, but I think it's important. And that is patients don't read the textbooks. And as we're moving towards patient-reported outcomes and including patients in shared decision-making, day one of sleep clinic, you learn about the difference between sleepiness and fatigue. But in Ron Chervin's data, the number one symptom in obstructive sleep apnea is fatigue, not sleepiness, because patients don't read the textbooks. And so Bernie Sunwood and my group, we recently published a study on what we call the language of sleepiness. And the variability is striking. The number of people that have non-restorative sleep or wake up feeling groggy or need a lot of coffee or they feel really tired. Lots of people with normal Epworth scores are profoundly symptomatic if you dig into the history. So I'll let the others address the question you just posed, but I will say every patient's different, and it's very important to ask, what do you mean by hypersomnolence? Because it's not it's kind of a crapshoot.
Yes, it is. I agree with you. And I think the lexicon is one that is really important. We just had 2 publications on that as well, of the lexicon and the language used in regards to the management. You're correct. What someone's coming and saying and what you're actually listening to and hearing might be very, very different. Emmanuel, I'm going to have you give the first kind of addressment of sleepiness, hypersomnolence, hypersomnia. Same but different. What is your perspective? How do you educate on this?
I think there's, again, the mechanism. I think the mechanism, we started to talk about it, which I think is interesting. This general idea that maybe sleepiness could have more circadian origin or sleep debt origin. Should we improve sleep at night or promote wake during the day? I think it'd be wonderful if we could have better assessment of sleep debt, chronic and acute, and circadian phase in patients to better understand what we need to treat, as opposed to just randomly giving something that makes them more awake or sleep better, which we have no idea why it works. So that would be one comment, which I think is directly relevant to what we discussed. The second comment is indeed, just what is really sleepiness, which I really dislike these notions because they are all a matter of definition. But clearly there are many dimensions, and people call sleepiness or fatigue things that are quite different. Even when we use the MSLT, we measure the ability to fall asleep. It's not really sleepiness, it's sleep ability. And the MWT, we try.
That is a very important. I want to underscore that of what you just stated. The MSLT is a measure of the ability to inappropriately fall asleep. It is not necessarily a measure of sleepiness.
No.
This is why
and not even inappropriately.
Huge difference. Yes. So I think that is a very
inappropriately. We put them in a bed. I don't find it inappropriate when they're in a bed.
It's also
so
MSLT is measuring ability to sleep at the inappropriate circadian phase, right? That's the test there. It's not it's not telling you what you think it's.
No, it's not entirely appropriate. I'm sure that a tool would think that going to take a nap right now maybe is not would not be okay. But you're right. As a hypersomnia specialist, I'm more open to taking a nap anytime. But you're right. So I think that's important. We don't really measure always the same thing, and then reaction time and et cetera. Those are different aspects of sleepiness. And then the perception, the cognitive. I mean, even when you just do the Epworth, it's very interesting. People don't discuss it, but you just have 2 factors. You have sleepiness in active situation and in passive situations. So it's just 2 subtypes of sleepiness. You fall asleep after lunch, in a quiet situation, or you fall asleep in a red light, you know. I mean, that's really different. So I think sleepiness has many different dimensions, probably many different causes, and we neither study the dimensions nor the causes right now. So I think there's a lot of work to do.
So I'm going to just move on to the next slide, but some of the points that I would just want to make with this is sleepiness can occur in anyone. It can be temporary, it can be chronic. And so understanding, to Emmanuel's point, the underpinnings of why there is sleepiness, making the distinction to others. A patient with idiopathic hypersomnia has made the comment, the distinction between sleepiness and fatigue may have contributed to my delay in diagnosis. It's so important to educate patients on this too, because it's so hard to describe your symptoms sometimes. And just as they're not reading the book, they're also writing their own books as they go along, of giving us new words to be able to get a definition or a description of what it's like to live with this, because the sleepiness that I may experience from sleep debt may be very different from the sleepiness that someone is living with who has idiopathic hypersomnia or narcolepsy, and therefore to invalidate their lived experience but by them not meeting the textbook is absolutely wrong. When looking at hypersomnolence and hypersomnolence, I'm excessively sleepy despite relatively adequate age-appropriate duration timing of sleep. Hypersomnia is I am sleepy despite age-appropriate sleep, and I'm sleeping longer than that. So really, that is more of a kind of nod to the excessive duration of sleep with the sleepiness, where with hypersomnolence disorder, you may not have excessive duration of sleep. And that's true of narcolepsy. Narcolepsy more fits hypersomnolence, and idiopathic hypersomnia more typically is fitting IH. So I do think that just understanding those distinctions, our basic principles are really important. When we're looking at the central disorders of hypersomnolence, this is really what we're seeing when you're looking at the ICSD-3 TR. This is the characterizations. I think today we're going to lean into these last three right here. And I think that this is an important area for us to discuss, because of the fact that we do see that there are overlapping phenomena that these individuals experience. However, there may be some unique characteristics that you may or may not get in report or in another way of characterizing. Thoughts?
I have one or two comments. There's a couple of things in the chat that we might want to address about patient-reported outcomes. In the sleep apnea world, the PROMIS scales are getting a lot of traction that the NIH developed as the sleep-related impairment about daytime symptoms and sleep disturbance scores about nighttime symptoms. At least in some studies, the data suggests that those are sensitive metrics to the CPAP effect in sleep apnea. So those are, I think, evolving. I don't know as much data in IH, but I think that's worth, discussing it a little bit more. The other point I want to make, just along the lines Emmanuel was saying, there's a paper he wrote, or he's a co-author on, that I often quote about the utility of the MSLT. And other than in type 1 narcolepsy, it looks like a fairly useless test as far as I can tell in terms of reproducibility and stuff. So I'd like Emmanuel's comments on that, because I frequently quote that as a source of concern for the MSLT.
Emmanuel, thoughts?
Yeah, I think, this picture is useful to show how complex it is. And unfortunately, I think someone made a couple of comments about the Stanford sleepiness scale and the Epworth, and those are so crude. It's just what we're really using now is very superficial measure of what's really happening in terms of daytime sleepiness. Is that difficulty finding us, like staying up with sleep attacks? Is that like brain fog? Is that sleep inertia? Is that dissociated sleep? There's all kind of different aspects which we see in patients with hypersomnia, and narcolepsy, and that I think are not really well captured. We certainly not capture at all with an Epworth and just an MSLT. So I think we need to develop new instrumentation. That I'm pretty convinced. So people are trying, and certainly there is a narcolepsy severity scale or idiopathic hypersomnia severity scale that Yves has developed. Yves Dauvilliers, that's a good point. Sometimes these scales, the problem is they often mix up potatoes and carrots and oranges, and they just do an overall score, and that's it. And so I think we probably even need to improve on that to really like define better subsymptoms and see how they are different, do factor analysis. There's a huge agenda ahead of us, I think, in this area.
And I think Kieran Maskey has done a good job in developing some of the pediatric scales that are being utilized, so the pediatric hypersomnia tool, as well as the pediatric narcolepsy patient-reported outcome scale. So I do think that there is investment in trying to expand this. Phyllis, I'm going to flip to the next slide, but I want you to make your comment.
Yeah, I just wanted to ask the panel, what do they think is the biological basis for sleep inertia, given that it's, you know, in narcolepsy, you see that in IH, you see that in circadian disorders. So is there a way to measure that, being that it's probably one of the debilitating symptoms that our patients have? Is there a way to think of that, and it may be confused with sleepiness as well to some extent?
I mean, I think that in narcolepsy type 1, we see sleep inertia less. I think in narcolepsy type 2 IH, we definitely see it. And I think for me, the concept that I've always considered it is, if I were to use that two-process phase, is an over-exaggerated homeostatic drive, or too much of that sleepiness. So thinking about sleepiness, is it inadequate wakefulness or over-exaggeration of sleepiness? Being that over-exaggeration of sleepiness. But Emmanuel, I would love to hear what your comments are.
Yeah, I have a little bit similar, but not exactly the same opinion. I think first I want to say yes, that in narcolepsy type 1, sometimes you see sleep inertia in children, but if they are reasonably well treated, it's true that it's generally not a major problem. Whereas in idiopathic hypersomnia it is, or in circadian disorder. I think what would be very interesting to start to look at, which we have done in narcolepsy, and we have very interesting data, is to look at regional differences in sleep and in sleep. So as you probably know, we developed these new measures of hypnodensity, where we have probabilities of different sleep stages, you know, instead of just one sleep stage versus another. And we have done some studies looking at the differences between, you know, the probability of REM sleep, probability of non-REM sleep in the frontal area versus the parietal versus the occipital. And it's very interesting. And for example, we found actually that there are some differences in narcolepsy, that there is some dissociation, more dissociation in REM and wake locally, which is surprising, and not non-REM. You know, across these different electrodes in terms of probabilities that could reflect against some of these dissociated symptoms. I mean, REM is often sort of a global phenomenon, but maybe narcolepsy, you know, it may be more in the occipital area. That's why you have more hallucinations. Or, you know, that could, you know, some of those regional differences could be important. Similarly, for
especially over time, knowing that the connectome changes over time as well. So those regional differences, and then also, what is your baseline genetic predisposition to where you may be the most dominant, and are you one side of the brain dominant versus the other? I think that there are so many contributions, and I think some of the work that you've done, not only in terms of your machine learning to be able to understand even the probability of there being narcolepsy, as well as these regional differences, also most recently your assessment of the MSLT, and both the napping and in-between napping, and being able to have some predictive modeling as to what there's someone's cognitive performance, as well as likelihood for a diagnosis of narcolepsy. Now, I want to just switch gears just to be mindful of time, not to cut off anyone, because I could talk about these topics all day, obviously. But I do think it's important for us to start connecting some of the therapies that we're utilizing with some of the physiology, as well as what are people coming in and saying. So I have these slides to illustrate. And so this slide is looking at pitolisant, our alerting and stimulant agents, modafinil, solriamfetol, methylphenidate, amphetamines, as well as obviously armodafinil, and then also our antidepressants that we use very commonly in some of these conditions. But as you can see, I also have italicized here some of the other disorders that may be present, like nightmare disorder, parasomnias, sleep initiation issues, that may be not for necessarily narcolepsy, but for other conditions. I think that this becomes a really important contribution for people to think through, because as we've described, that we would love biomarkers, we would love have better understanding of all this physiology, but we're limited. but having an understanding of the physiology that we do know about and the mechanisms that we do understand and how these can be collaboratively used, a wise selection of one versus the other, and how to approach this, I do think becomes really important. When I look at having a novel mechanism of action, like something that works on the histamine system, for me, I'm like, that's a great utility player as long as there's not a drug-drug interaction with something else I'm utilizing. But I'm wondering, the orexin system is going to be covered in a future slide. With that, I would like to just get a sense from some of you in regards to, again, your approach to either your conversation to your patients or a conversation with your trainees with this slide. And then I'm going to go on to the next slide for the oxybates, just so that we're covering all those. The orexin system will be on a future slide. Tell me a little bit of what you think about, or how do you discuss this, and where else do you use it outside of your hypersomnolence disorders? How has the use of this in maybe narcolepsy informed your practice in IH? And then how has it informed practice maybe in obstructive sleep apnea with sleepiness? So anyone want to kick it off? And this is going over the oxybate piece and giving some considerations around the use of gamma hydroxybutyrate, which is the main product within your oxybates, and its potential relevance in neurology. And I put this slide specifically because of the fact that we are seeing an explosion in the literature right now about the use of oxybates across a variety of other medical conditions. Most recently seeing one in a movement disorder that was not Parkinson's or REM behavior disorder. It was more of a laryngeal spasm, and it being very effective. So Phyllis, you have your hand up. Go ahead.
Yes, I wanted to make a comment about the previous slide. It just occurred to me when I looked at it, I thought, wow, to be stably awake, to have stable wakefulness requires the activation of a lot of neurotransmitters. And perhaps that's the idea here in the future, is that we may need to address many of these and not just one or the other. So it's quite impressive.
Agreed.
I would make a couple comments about sleep apnea, just because that's the one thing I know.
Sure.
and we had a global consensus at Delphi conference that Jorg Stier in England and I chaired. It was interesting, the global variability. We couldn't agree on much of anything in terms of actigraphy wasn't available. Many places MSLT was not available and was questioned in terms of its utility. So there was general consensus that treating residual sleepiness and sleep apnea was a good idea. Optimizing primary therapy for sleep apnea was a good idea. But then which agents to use was also quite variable. Where I am, it's hard to get anything other than modafinil, Provigil, or armodafinil, Nuvigil, first line. Even in premenopausal women, where we know they interfere with birth control pills and we know they're teratogenic, kind of a double whammy, even then it's hard to get some of these other medications. I will say, full disclosure, I was involved in a lot of the Sunosi solriamfetol studies, so I may be conflicted, but I have had very good luck with that drug clinically in terms of efficacy and safety.
Yeah, and it also has a great safety profile for women because it doesn't interact with hormonal therapies. And in animal models, it's really demonstrating that there may not be cause for concern for teratogenesis. Obviously, I wouldn't say not to have any concern, but when compared with some of our other agents, that may have a more preferential profile. Phyllis, did you have something you wanted to add? I'm sorry. No? Okay. So again, because of time, I will go to the next slides. So as promised, we are going to talk about orexin. So orexins project to all major sleep-wake centers. And really what we see is that it not only is influential in terms of our sleep-wake states, but really does have other contributions external to that. And we'll talk about that in a second. For a tool, we also are seeing the relationship to the cardiorespiratory homeostatic reflex pathways. And so clearly may also have a significant role in the future for as we're looking at orexinergic medications for obstructive sleep apnea as well. So Emmanuel, I'm going to kick this to you first, and then I'm going to go on to the next slide just so that we can see further illustration around some transdisciplinary considerations.
Yeah, I think what I would like to say here is that, of course, that's always ongoing when you start a field of because you always oversimplify, because the oversimplification has value. But of course, in the details, the oversimplification is always wrong. We saw that with the two process models that we discussed. And similarly, trying to say that orexin is just a weight-promoting compound, and I mean, that's just a fantasy, because obviously when you look at the orexin system, it projects everywhere in the brain, and it must have a tremendous amount of function. And in any case, the idea that one neurotransmitter, one function, is kind of outdated. Nobody really believes it anymore. I think orexin may be one of the few exceptions where it's relatively purely sleep. But we should not forget that most systems can be compensated very effectively. I mean, we know that people can have hydrocephalus and just like this cortex of that left, and they still function quite well until 100%. They don't. Yes. So the rule is compensation. And what we see in a lesion like the orexin is not its overall role, but rather its roles that cannot be well compensated when it's being lost. Sure. So that's one point. The second point is that for sure, and that's what is really expressed here in this very complex diagram, the second point is that, again, our measures are crude, and we all agree that we have been treating these narcoleptic patients with that orexin for quite a while, and we see some great improvement with the drugs that are symptomatic, but they are never completely improved. And we always have felt that there are some issues with motivation, with difficulty of getting things done, maybe things that just cannot be very easily measured that are a consequence of orexin deficiency. And curiously, the best way to really see that is to replace it. And we only start to see it now that we have the tools to replace it. So I think this diagram is very important because it reflects the fact that orexin is not just a sleep transmitter, probably much more complicated, and many of the defects will be compensated, but maybe not in everyone, and that will still leave a vulnerability. Sorry, it was long, but
No. I think that this leads us, because we're not leaving orexins, we're only digging into it further. And I want to get into not only continuing the points that you're making, but really starting to also unveil those transdisciplinary considerations. You're correct. We have some experience now with DORAs, the dual orexin receptor antagonists. We now are getting some experience with orexin 2 agonists. And I think that having this conversation around the transdisciplinary considerations, not only to frame up what does the burden of living with these disorders look like, but also who else should we be considering this in, because of the fact that there are other organ systems that are going to have implications from orexin dysfunction. And so when we're looking at kind of the orexinergic system, we can see that there is publications that are plentiful that are looking at not only this arousal regulation and sleep-wake transition, but to Emmanuel's point, talking about reward-seeking behavior, feeding, autonomic and neuroendocrine axes, cognition, nociception and pain control, addiction. We're seeing this with the DORAs, that this is something that we can utilize to help in reducing the likelihood of someone to relapse into substance use disorder. So not only modifying the sleep-wake behaviors, but also modifying this drug-seeking behavior. So looking at the fact that it's not that it's just sleep-wake, it is impacting a variety of areas. And we're going to continue to talk about this in a second, but I just want to give the illustration of when we're specifically thinking about narcolepsy, we talk about the pentad, right? Excessive daytime sleepiness, cataplexy, sleep paralysis, disturbed nocturnal sleep, sleep-related hallucinations. But that is really like the tip of the iceberg when we start seeing all the other areas. And this is just a smattering. It's not even really comprehensive. I would want to just throw out to the team the question of that is put in the chat. There's such an overlap of course, symptoms going on often in unison. This seems not to get noted nor mentioned. For instance, sleep attacks involving excessive daytime sleepiness, sleep inertia, sleep paralysis, the sleep-related hallucinations. The terminology is huge and currently exacerbates further confusion. Take muscle weakness being part of sleepiness, but used for cataplexy. how do you educate doctors when clearly there's a gap in this terminology? I would say that I first like to what Atul had said earlier is asking, what do you mean by XYZ? By really utilizing the patient's own words of what their lived experience is, it can help you have better clarity of what is my goal? What am I actually hearing this patient say that they're challenged with, and what actually can I do to help in influencing it? But I throw that out to any of you are there any specific areas that would be helpful, like any language that you would utilize that would be helpful?
I'll just reiterate what you said. I think just talking to the individual patients in shared decision-making, but what do you mean by such as that symptoms? I think the rookie mistake is to impose symptoms on patients or try and disprove them. So I'm a lung doctor as well. When it comes in short of breath, I don't try and do pulmonary function testing and tell them they're not short of breath. Obviously, if they're experiencing that symptom, we need to address it, even if we can't explain it.
Yes. And I think that's an important point, because I think a very common cause of delay in diagnosis is patients not meeting the criteria on the MSLT and then being told there's nothing wrong with you. So invalidating their experience with sleepiness or whatever it is that they're challenged with, and not actually trying to create a pathway forward. So I think that's really important, is treating the person in front of you, starting with that.
The other point to make there, if I may, is that we often ignore the chief complaint. So people come in with snoring, we get a home sleep test, send them away, so you're fine. Well, you didn't address the chief complaint. Same with, I see this all the time with sleepiness. People come in, they get a home sleep test because that's all the insurance will cover, and told they're fine, go away, and they have a disorder of central hypersomnia that's ignored. So I think digging into that history is important. How to educate doctors about it is, we do things like webinars like this, we do direct to consumer, we do professional society meetings, et cetera.
Yeah, I think those are important.
Yeah.
Go ahead, Emmanuel.
So I think, again, there are probably several levels of integration, or at least how I see it. There's one level of integration, which is simply the symptom of the patients and how it is being described by the patient. And that's what you treat, so you have to pay attention to it. And indeed, unfortunately, it's limited by language. Language doesn't reflect neurochemistry. That just will never do. It will just reflect what people think. It's variable depending on culture. It's intellectually challenging to even think that the people mean the same thing with the same term. So the only thing you can do is do your best to try to isolate various dimensions with different names and terms, which can help you to precise clinically the symptoms. But then I have the strong kind of bias that I hope we can get better into biochemical dimensions. For example, through proteomics or measuring the brain or imaging or EEGs, etc., which I think are less likely to be dependent on this or test on this verbiage, which at the end we can have very nice discussions in very nice places for hours and hours to precise, and I hope that we'll get more molecular as we move forward, but it's a challenge. That would be my electrophysiological. That would be my only kind of general comment.
Yes.
I would prefer to have neurophysiological tests or biochemical tests to reflect some of these processes, because they will be always more reliable.
Yeah, and I think that there would be helpful not only for the diagnostics, but prognostics and therapeutic response as well.
But it's not what you treat, so that's very important to realize. I mean, to the point of Atul, you don't treat, you don't treat orexin level. You treat narcolepsy. So of course, that's a different discourse, But
take that even further, Emmanuel. You don't treat narcolepsy. You treat the person who is living.
Yeah, right.
Right. So
exactly.
Phil,
That's even better. Yes.
Yeah.
Yes.
Absolutely. Yeah, for each level of sleepiness, it depends what the person does, right? I mean, how alert they have to be. So along those lines, Emmanuel, I was going to ask you, what do you think about something like the wake EEG that can be done very quickly in the clinic, right? In a nice quiet room? Would that be something that we could look at for level of sleepiness? And you could do that any time of the day. So you could get the circadian measures if you wish. You could always do it at the lowest time. What do you think? Is that possible?
Ambulatory EEG would be even
Oh.
better.
No, just a wake EEG, quick, 2 minutes.
Yeah, no. It's possible. There are two. It's possible. For example, I think Anne-Marie mentioned something. We looked at between naps, and one of the things that came up is the increased probability of REM sleep during wake between naps in patients with narcolepsy. Well, it's not like super overwhelming, but it kind of suggests maybe if we start to look at different brain areas, maybe we can find something
Yeah,
that
but
would be
maybe
better.
something we can charge for now in the clinic.
Ah,
Something we can charge for in the clinic if we actually validate this.
Yeah, it's like
I
the
know. So the
ADHD beta alpha ratio.
I know. The problem is data, as usual, and is having the data to test this hypothesis. And I would like to say that I'm concerned that this is becoming harder and harder with all this paperwork to get any data, to share any data, to work
Sure.
together. It's just
Sure.
becoming a
I agree.
nightmare. So I don't even know if it will be doable with the current situation. Because if I want to get these data, I need 6 months of paperwork, so that's a problem.
So I think if we zero back into just where we are, and I agree with you, these are conversations within our last 11 minutes that I will want to come back to, of being able to say, what does the future look like? But some of the things that we already know is that we have experience utilizing the orexin receptor antagonists, and we see where they can be beneficial and utilized. We do see, again, variability in response. We do understand what their safety profiles are. We understand that they're starting to be utilized in other conditions, and there's benefit. I've already alluded to substance use disorder. There's evidence of them potentially being helpful in at least animal models with intractable epilepsy, and being suggested that might be something that may be beneficial for SUDEP prevention. So there's all these other areas that, again, are giving you this really keystone understanding how orexin may play a role in other areas. When we are thinking about the orexin 2 agonists, we recognize that they're currently being designed and studied for narcolepsy type 1. We have the TAC-861, we have the ALKS 2680. We have some other molecules that are in phase 1 that are also being evaluated. However, there are probably some other areas of consideration that may be relevant. So one, we've talked about how orexin is so instrumental across all these other areas. I have over here the endocannabinoid system, sex hormones, others, and really that's because of the interaction that we see it playing in regards to some of these other areas. Atul, you have experience with the tirzepatide study being utilized in the treatment of obstructive sleep apnea. There's data that demonstrates that GLP-1 agonists have interaction both direct and indirectly, peripherally and centrally with the orexin system. There's also evidence to demonstrate GLP-1, given the differential timing in the day, may also influence what your ultradian pattern is, may potentially increase slow wave sleep. So giving other suggestions, especially when we're looking at the orexin implications in cardiorespiratory centers, I mean, that is one illustration that I would say that we see there. I don't know if you have any other thoughts in regards to that particular interaction.
Yeah, there are a couple of questions in the chat that I could address in that context as well. There are some receptors in the pre-Betzinger complex, in the respiratory rhythm generator that Jack Feldman described as where the breathing pattern occurs. There are orexin receptors there that you can stimulate. And so I think that is an important thing to be aware of. How important they are clinically, I don't know. I don't think it's a big factor, but at least something to be aware of. You're quite right, though. The tirzepatide data we published, again, full disclosure, I was the global PI for the SURMOUNT-OSA study published in New England Journal recently, where we showed improvement in sleep apnea in both CPAP-treated and non-CPAP-treated patients with tirzepatide compared to placebo. So major weight loss in that context as well. But you're right, there is orexin stimulation that's been shown both directly and indirectly with this GLP-1 receptor agonist. How important chronotherapy is there, I don't know. Tirzepatide is a once-weekly injection, and so it's a very long half-life. Some of the animal studies with very short-acting medications may or may not be relevant in that context. I think probably we need more data there. There was also a question about central apnea. I think with orexin deficiency, fragmented sleep that's often seen in narcolepsy, that can certainly affect breathing and central apnea through sleep state transition type things with CO2 fluctuations and whatnot. And
Yeah.
one final
And-
point. Sorry.
I was going to just ask, with the question about the orexin and tidal volume, you would say that we don't have enough evidence to say, correct?
It can stimulate the prepancreas. I think there are, in high doses, there are effects that are seen in animal models. I don't think they're that important clinically in terms of what we see with orexin modulating drugs, either agonists or antagonists. The other point I was going to make, though, was about DORAs. I saw some data recently, a randomized crossover thing where they're looking at fat breakdown, fat oxidation, and whatnot, and that was in a randomized crossover study, a big effect across all stages of sleep in patients on drug compared to the same patients off drug in a randomized crossover study. And then we have some data, I'm just working on the publication yesterday about some of these DORAs in mild sleep apnea with comorbid insomnia, that COMISA, showing some potential benefits there as well. So I think it is an exciting area.
Yes, yes. And I think it's an important one to call out because I think that many times, because we're not reflecting on what mechanisms of drugs are and what the physiology and how this physiology informs on the different endotypes or phenotypes, that we're not necessarily expanding all of the options that may be best for the person who's in front of us. Emmanuel, Phyllis, any other thoughts around these concepts?
No, I was going to mention that you did mention shift work sleep disorder as another potential area. Neurodegenerative disorders, where the orexin system may also be, an agonist could be quite helpful as well when you look at the orexin 2 agonists, for example. So I think there's any place where there's that interplay between circadian and homeostat, which is most of our sleep disorders. There's potentially a role of both wake promotion, but also sleep promotion, right? Right now, most of our drugs have been on the sleep end. And as we saw, it's really both sides are really important.
Yeah, and to add to that, I mean, we also are seeing other wake promoting agents that are being developed that are delayed release and extended release and utilizing the GI environment to be able to produce. So we do see a methylphenidate formulation that is in phase 3 now for idiopathic hypersomnia that may help with some of those issues as well. So I do think us having all these different options available so that we can tailor them to the person in front of us does become really important. Emmanuel, in regards to you, I think you are one of the people who have probably the most experience with the orexin 2 agonists that are currently being developed and in trials. I would love for you to share some of your experience with what these medications have looked like for your patients, because I always think that this is such an exciting thing to hear.
Again, I think besides the effect of wake promotion, which seems to be quite striking, because I think it's not really the same league as what we observe with amphetamines and so forth. The MWT would move from 2 minutes to 40 minutes, and without people being crazy. I mean, if you were trying to give amphetamines to narcoleptic patients and make them at 40 minutes MWT, I suspect they will climb the wall or be like like a polar bear in a zoo, like having stereotypies. So they look different, but of course it's kind of a bit early, and then in idiopathic hypersomnia and narcolepsy without cataplexy, it's similar, but you have to use a higher dose. But I don't think we really have enough information about, I think we discussed the fact that qualitatively they also do something a bit different in the patients with narcolepsy, that the narcoleptic patient seems to engage in their life in a very different way versus before. And what exactly does that mean? This increased motivation, could it be also useful for other disorder, psychiatric disorder, neurological disorders? All this is open. I think, we'll discover. There's even one last thing. I mean, like one of the things that surprised everyone is with orexin agonists, people had increased urinary urgency. They needed to go to the bathroom regularly. It's not dramatic. They don't pee in their pants, but they really need to go to the bathroom more often. And I remember when I saw some of my first narcoleptic patients and I gave them Strattera, some of them had urinary retention. And now I kind of realized that was probably partially related to this when they were starting narcolepsy and I was giving them an adrenergic reuptake inhibitor. But that being said, now the antagonist, I know that there is a clinical trial that has been done where they are doing trying in increasing urinary frequency during the night. So, for example, an orexin antagonist could be maybe good for people who have prostate problem, better than at least another sleeping pill. So there is definitely a wide range of things that could be sort of psychiatric, neurological disorder, comas, I mean, all kind of things. And of course, not to mention aspects of breathing physiology, etc., because we know that this chemical doesn't just work on what we see. It has a lot of neuromodulation and other effects that will be more minor.
Yeah.
I think as a pharmacologist, the only thing you can say is you have to try. Anything else is just speculation. It could also turn out that these drugs are going to be the most abused drug in the planet. I don't know. I mean, I'm not completely sure. I don't think so, but it's because it doesn't look like it's addictive, but it's very difficult to know until these drugs are actually available and used, and you have to proceed cautiously and test the hypothesis.
I must confess my jaw dropped when I saw the New England Journal paper you're on, Emmanuel, last year, the orexin receptor 2 agonist, I think, with stopped for hepatotoxicity, but the epithets went from, I think, 18 to 3 or something. I've never seen anything like that. It's
the ceiling effect on an MWT. I mean, they really are quite impressive. But I would say that even though that one was stopped, the other medications that have been continuing to be studied are demonstrating pretty remarkable safety profiles outside of the urinary concern, which improves over time, but also the wakefulness it's still pretty substantial. Would you agree, Emmanuel?
No, absolutely. I mean, I didn't want to say that because, of course, I'm biased. I was involved in the initial discovery. So, I've always tried not to be a proselyte of your own discovery because it's kind of bad. So I just want to put a little bit of a word of caution. But of course, it's a very new, exciting area. The other thing we don't really know is long-term effects. I mean, we don't really have a long-term, we have some of these patients that have taken it for 1 year. We see that the effect is maintained. Whether or not it's maintained exactly at the same level, all these things still need a lot more work. But in my opinion, it can only be better. We just have to learn how to use it better. That's for sure. But that's very, very exciting.
So
I want to mention there were one question about the orexin receptor 1. I think that we should not forget the orexin receptor 1. I mean, there's no doubt that orexin receptor 1 and 2 are both involved in wakefulness. We know that from genetic study, polymorphism in receptor 1 and 2 are associated with various sleep phenotypes. And we know that injections of orexin receptor 2 knockout mouse of orexin still promotes wakefulness through the orexin receptor 1. So we are really using only probably the most important half, but there is additional stimulation through the receptor 1 that we're not completely compensating with receptor 2 agonists.
Sure.
People have been cautious about receptor 1 because in this one, there is suggestion that it could have some abuse potential. So people have been a little bit from animal studies, but animal studies, I don't know how much predictive they are for what's happening in humans. So I certainly think that's another whole area of great interest.
Yeah. Well, believe it or not, guys, we just did 90 minutes of talking nonstop. But I would say to you that this felt like 5 minutes. It is always such an incredible opportunity to be able to spend time with the three of you. I always learn so much, and I have to say that it's always fun and different. And Emmanuel, I hope that this was more fun than what you were expecting, because he's in Paris. So I'm sure there's other things that were a lot more fun than being on a Zoom call with us for 90 minutes. But I hope it was worth your while. As you could see during this entire conversation today, we've been talking about moving forward and how discovery and development is going to change tomorrow. We already see that it's changing today. And we are absolutely thrilled with all the questions that came in throughout this presentation. There were over 20 questions that were answered live while we were able to engage. I apologize if we were not able to get to your question. However, that really made it a lot more interactive and very much appreciated. We would love to know what else would you like to see covered on the state of the science by the Sleep Research Society Foundation. And we would be amiss if we did not again thank our corporate sponsors for their contribution to be able to make this webinar possible. This webinar has been recorded and is available at the sleepresearchsociety.org/foundation. And if you've missed any component of it, or you want to revisit it because I talk really quick or we were interrupting one another, this just goes to show you that this is non-scripted and absolutely a true conversation for you to get a reflection on. This is how we're talking about it. These are questions we have. We're certain that you have the same questions, and we hope that the questions that we did answer for you helped you to inform on your clinical practice, but potentially also has unveiled some future research ideas. We want to thank you. We appreciate all of the questions that had come in. And of course, Phyllis, Atul, and Emmanuel, this was absolutely incredible. And I truly appreciate your time this morning. I know it's super early for you guys. And Emmanuel, I'm interrupting Paris, but you can have a croissant on me while you're there.
Thanks very much, Anne-Marie.
Thank you.
White wine.
Bye,
Bye, guys.
No wine.
Bye-bye.
Bye-bye.